Good evening, doctors, and welcome for tonight's webinar. To start, let me introduce to you our moderator for tonight's lecture. Our moderator is a diplomate and fellow of the Philippine College of Physicians. She is also a fellow of the Philippine Society of Diabetologists. Our moderator earned her diploma in internal medicine, major in diabetes, at the Institute for Studies on Diabetes Foundation, Incorporated. She is also the past president of Oriental Mindoro Medical Society. Currently, our moderator is the National Chancellor, Diabetology of the Philippine Academy of Medical Specialists. She's also the current president of Diabetes Philippines Oriental Mindoro Chapter. At present, she is the board of director and head of the Diabetes section of Medical Mission Group Hospital in Calapan City. Doctors, please welcome our moderator, Dr. Jocelyn Muli Marcos.
Thank you very much for that kind introduction. Good evening, colleagues. Welcome to the first webinar series of Glorious Dexa Mandaya Incorporated. We all know that 2020 was definitely not a very good year, as the pandemic had caused a remarkable twist in the lives of all of us globally. So the year of the rat started with much fear and anxiety as we bravely faced our battle with an unseen enemy. And by the passing of months, we were able to adapt. So some of us got the infection, despite adherence to standard health protocols. There were so much lives lost, particularly amongst us frontliners, but still, we are very thankful that we are safe and remained healthy. So we keep our fingers crossed that this year of the ox will be ox na ox. Our continuous quest for updates and learnings are still provided by the webinars that made attendance easier and more convenient, that is at the comfort of our homes. So tonight, I am tasked to moderate on a topic that has drawn so much interest for us doctors, not only for its title, but also for an important discussion for us treating patients with diabetes and peripheral arterial disease. So for your inquiries and verifications about the lecture, you may type in your questions in the chat box, which we will tackle during our interactive discussion after the lecture. Let me introduce to you our speaker. Our speaker for tonight is a diplomate and fellow of the Philippine College of Physicians and the Philippine Society of Diabetologists. He is a Master of Science in Internal Medicine, major in diabetes, and he is the immediate past president of the Philippine College of Physicians, Central Luzon Chapter. He is vice president of the Philippine Society of Diabetologists. Our speaker is an esteemed faculty and training manager of the Institute for Studies on Diabetes Foundation, the PSD, and the Philippine Association of Diabetes Educators. He is consultant in internal medicine and diabetes of Heart of Jesus Hospital, San Jose City in Nueva Ecija, and Dr. Paulino Garcia Memorial Research and Medical Center in Cabanatuan. Dearest colleagues, to discuss on the good, the bad, and the ugly, Disolf, diabetes, and PAD, let us welcome my very good friend, Dr. Danilo Baldemore.
Doctor, the audio.
Doctor muted.
Yan. Kita na yung slides ko? Okay, let me share again. So, as I was saying, sabi ko, thank you kay Ate Georgie. Oh, yun ang atin namin din dito. Yeah. Okay. So,
Yeah.
Thank you. Thank you also to Sir John for the invitation to talk to you again in Glorious Dexa Medica. So, let me start. Okay. So, again, during this pandemic, we are very much more of a virtual learner. And a quote from Robin Sharma telling us that a day without learning is like a day without breathing. So we continue to breathe and then we continue to learn. So a very Zoom evening to each and every one. So the title of this lecture is about the good, the bad, and the ugly. Siguro yung mga iba sa inyo na mas bata pa sa akin o mas bata pa kay John ay naalala itong pelikula ni Clint Eastwood. So this is about 50 years, o actually 55 years na nung unang naipalabas. And i-connect natin ito sa ating topic for tonight. This is the good, the bad, and the ugly, which is Disolf, diabetes, and the bad. So the objectives of this lecture is we'll be discussing about peripheral arterial disease, its causes, assessment and screening, and some recommendation on food care that would be beneficial to our patients. And then talk about treatment including dissolve. So let's start with the ugly. So ano ba yung ugly dito? So ugly is your chronic complications of diabetes. And with that, ito yung macrovascular complications. So with diabetes, it would involve the large blood vessels of the brain. So magkakaroon ka ng stroke. Then the patients can have blockage of the vessels of the heart, kaya nagkakaroon ng heart attack. And then if the block is in the legs and the feet, then you will have the peripheral arterial disease. And we know that 80% of all diabetic mortality would come from diabetes, would come from the uh, coronary atherosclerosis, and 25% would be involved the cerebral and peripheral vascular disease. So you can see medyo maliit yung vascular o peripheral vascular disease. At minsan, it goes unnoticed. Okay? Kaya hindi rin masyadong nadadiagnose or kinocomplain ng mga ating mga patients. Now, pag sinabi naman ng peripheral vascular disease, it encompasses not only the diseases of the arteries and veins, but also the multiple underlying medical conditions such as coronary artery disease, diabetes, and renal insufficiencies. But minsan nakapag interchange yung PVD and PAD. Okay? So let's talk more about peripheral artery disease. So these are the risk factors for PAD. So you can see the odds ratio for PAD increases if the patient is smoking or with diabetes and hypertension. Yung meron mga hypercholesterolemia, those with CKD, and history of coronary artery disease. Now, this is a study by yung partners, the PAD awareness, risk, and treatment, looking at almost 7,000 patients in the physician's office. So they found out that 29% of patients were diagnosed with PAD. Okay? Ito yung may mga history of smoking and diabetes. So ang laki niya na from 7,000 patients. Now, 1 in 3 people over the age 50 have diabetes, also have peripheral artery disease. Now, this is the latest from last year. So it was already published from the Asian Pacific Society of Atherosclerosis and Cardio and Vascular Disease. Okay, so this is the prevalence of PAD in the Asia Pacific region. As you can see, dito sa atin, based on the community-based population, we have 15, almost 5%, okay, of the population. Okay, the leader is China, 15%. Okay, and then makikita rin natin dito yung mga outpatients with atherosclerosis or severe risk factors, madami sa Japan. Okay, almost 14%. That's why siguro the reason also, marami rin sa kanila rin may diabetes because we are both Asian countries. Okay, Singapore is 8.2 and in Australia it's already 10.1%. Now, let's talk about assessment and screening. So how do we establish a diagnosis of PAD or assess its severity? So may mga nag-games pa pag naka-quarantine tayo, di ba? Ang dami nating pinagkakaabalahan para mabawasan yung ating anxiety about the pandemic. So I'll just show you 4 pictures at tulaan nyo lang po kung ano yung word. Okay, so this is the second. This is the third picture. Okay, so mukhang may nakakasagot na. And correct kayo if your answer is pain. So is pain a manifestation or a symptom of a patient with PAD? Now, I'll show you the algorithmic approach and pathway to PAD diagnosis. Okay? So, may algorithm naman na ginawa na sila. But let's talk about the people at risk for lower extremity PAD or LEAD, ang minsan ang tawag din sa kanila, lead. So, those patients with atherosclerotic diseases like CAD or any PADs, yung merong other conditions like your abdominal aortic aneurysm, CKD, and heart failure are at risk. So, meron naman yung mga asymptomatic, kaya nga sabi natin, minsan undiagnosed kasi wala talaga silang nararamdaman, but they are at risk for lead. Kung ikaw ay age more than or equal to 65 years, you are at risk. So, siguro wala pa dito sa mga audience natin ang more than 65. Now, kung ikaw ay 50 to 64 years old with risk factors for atherosclerosis, like kung may diabetes ka, history of smoking, hypertension and hyperlipidemia, and history of albuminuria or CKD, or family history of PAD, then you are at risk. Now, yung mga less than 50 years old naman, yung mga type 1 diabetes or type 2 diabetes with one additional risk factor for atherosclerosis, they are still at risk. Okay? And then those with atherosclerotic disease, in other vascular beds, including the coronary, carotid, the renal, and the mesenteric. And this is also based from the consensus statement of the Asia Pacific. Sinama rin nila dun sa at risk yung mga Australian, Aborigine Australian. Now, only 1 in 10 patients with PAD has the classical symptoms of intermittent claudication. So, the classic symptom is intermittent claudication. So, 1 in 5 people over 65 has PAD. At yung nag-iisa na yan, only 1 in 10 has the classical symptom of intermittent claudication. So, in general, PAD is asymptomatic. Okay? So, now, in another study, these are the variable presentations. So you can see 50% of patients with PAD are asymptomatic. Yung may mga atypical limb symptoms are 30%. Those with the typical claudication is only 15%. And those with critical limb ischemia is about 2 to 3%. So napakaliit, di ba? So patient at risk should be screened for exertional leg symptoms. And of importance, only a minority of patients with PAD will report the classic intermittent claudication or present with the ischemic rest pain. So ano ba yung hahanapin natin pag may suggestive of PAD? So again, yung intermittent claudication. Yung ibig sabihin ng intermittent claudication, so the patient is symptomatic, naglalakad. Tapos biglang sasakit or there is calf pain. Upon resting, nawawala yung pain. Yan yung tinatawag natin intermittent claudication. The patient may have a typical leg pain. O ibig sabihin, kahit nagka-rest, nagkakaroon ng pain. There is functional impairment or ischemic rest pain. Or sometimes, ito na yung worst, pero na talaga siyang history of the non-healing wounds. So, what do we examine? So you check the pulse, particularly in the femoral, popliteal, dorsalis pedis, posterior tibial arteries. And then you classify or you grade the pulses as 0, absent, +1 or diminished, +2 or normal, or +3 if it is bounding. The pulse examination, however, is not sufficient to establish or exclude PAD diagnosis. Minsan, wala kang na-appreciate, pero hindi ibig sabihin, wala siyang pad. Or sometimes, may na-appreciate ka, pero hindi ibig sabihin, wala siyang pad. Okay? And then you may use a handheld continuous wave Doppler, or an iliac or femoral bruit may also be suggestive of pad. Then you examine, you do your physical examination, particularly the skin. You check for arterial ulcers. Okay, nakikita yan most commonly sa mga bony prominences, and this is typically painful. And then you check for gangrene, the mottled skin, okay, yung mga atrophic nails nila, and for hair loss in the extremities. Dati balbon, ngayon nauubos na yung buhok niya, o kaya sometimes you can appreciate medyo shiny yung skin. So again, going back to the Asia Pacific Society of Atherosclerosis and Vascular Disease Recommendation, these are the findings in the history and PE suggestive of PAD. So look at the symptoms and the signs. Okay? Now, ito yung mga recommendation naman nila. Okay? The level of evidence and the class of recommendation. So they recommended that patients at risk of PAD should undergo a comprehensive medical history and review and assess the symptoms related to PAD. So, pag sinabing level of evidence, ito BNR, or these are coming from non-randomized studies. Patients at increased risk of PAD should undergo already the vascular examination, okay? Including yung palpation of the lower extremities, inspection of the legs and feet, and auscultation of the fluid. Patients with PAD, meron na din mga non-invasive BP measurement or your ABI. Okay? So, ankle brachial index. So, you should do that also to your patients already at risk. Now, we want to minimize tissue loss. Okay? So, it is recommended that PAD and diabetes mellitus patients should be counseled about self-foot examination. Yung mga pasyente natin, hindi naman lagi natin nakikita. So kahit nasa bahay sila, sabihan niyo po sila, every night before going to bed, they should examine the foot. Okay? So, pati yung healthy foot behaviors, okay? Aimed at reducing the risk for foot ulcer and amputation. Okay? So, kung may mapansin na sila, then from diagnosis and treatment of the foot infection are recommended para hindi ma-amputate. And in patients with PAD already or signs of foot infection, kailangan i-refer natin to an interdisciplinary team. Okay, so pwede yan makita na ating diabetologist o yung ating internist o yung primary care physicians that kung kailangan refer sa surgeon, then we should refer to the surgeon for wound treatment. Okay? So, ito very important. Among patients with PAD at meron silang diabetes, foot examination should be included in every clinic visit. So kada punta ng patient natin, kahit wala silang kino-complain din, examine, especially kung nagkaroon na sila ng PAD. So again, to perform a proper foot examination, you check for structural abnormalities, particularly the range of motion, kung may makalyo na sila. You assess the peripheral artery by checking the temperature. Minsan, mainit sa kabila ang lamig-lamig na ng binti compared to the upper extremities. You check the ABI, and then for neuropathy, then you can do the 10-gram monofilament. So how do you do the 10-gram monofilament? So this is, you check the sensation, okay, using a monofilament on these 3 spots, okay? Okay, that test the 3 sites on both feet. Okay, ito yung sa may big toe, ito naman sa dorsum of the, ventral aspect of the feet. Sa ilalim, lalo na dun sa may bony prominences. So when do you do this? Okay, if the patient is low risk, you may do the foot exam annually. Kung high risk yan, ibig sabihin, nagkakasugat palagi or naputulan na siya, then more frequently every 3 to 6 months. And if the patient has already ulcer on the presently the patient has ulcer, then you refer the patient. Okay? Now, yung mga foot ulcer na, yung high risk for foot ulcer, then refer to a patient refer the patient to a foot care education. Okay? Kaya minsan pagsusuotin na rin natin sila ng professionally fitted footwear. And then if the ulcer develops, then you refer to the interprofessional team with expertise in foot ulcers. So, sa area nyo, kung wala pa po, you may refer them dito sa Maynila. Meron po tayo dyan, specialist. Now, ano yung mga naapektuhan? So, these are the arteries most commonly affected by PAD. So, hindi lang po sa lower extremities. It can involve the iliac, the femoral, the popliteal artery, and down the line. Okay? So, tandaan nyo lang po yun. Now, just to compare, if the ulcer is arterial or venous, ito yung difference. So, kung arterial, there is usually intermittent claudication pain. Walang edema. No pulse or weak pulse. Okay? Kaya merong round and smooth sores. And then there is production of the black scar. Parang may gangrene siya. As compared to your venous ulcer, minsan masakit po yan with lower leg edema. Di ba? Mas maga siya o mas manas. And then the pulse is present. Okay? Nagdi-drain yun kasi nga maraming fluid. There is sores with irregular borders. Okay? Slap, yellow slap, or ruddy skin. Okay? Usually, the location of venous ulcer is at the ankle. And the location of arterial ulcers, usually at the tip of the toes or the toes and the feet. So, yan ang difference para ma-compare natin. Ito venous, ito arterial. Next. So, talking about diagnostic testing, di ba? Gusto natin i-refer para ma-check. So, you can do an ABI or your ankle brachial index. I'm sure it's already available in your area. Pero kung hindi pa po, you can ask our partners in Glorious DEXA, yung mga ahente nila o yung pharmaceutical representatives nila can help in screening our patients. Okay? Another way to test is yung Duplex Ultrasound. And then, kung medyo advanced na, you may do your CTA or your MRA. And this is how the ABI is done. Okay? So the ABI compares the blood pressure in your arms to the pressure in your ankle. So you get the brachial artery pressure using the ultrasound. And then sa posterior naman, you get the pressure in the dorsalis pedis artery and the posterior tibial artery. So ito yung mga location ng pag-check. Okay? So with the patient lying down or in supine position, you get the right arm first. And then pa-letter U ang pagkuha. So after the right arm, you get the right ankle and the right dorsalis pedis. And then you go to the left ankle and then you go to the left arm. Okay? So pa-letter U ang pagkuha ng BP. And then you have a formula, you get the highest ankle systolic blood pressure divided by the highest R systolic blood pressure. Okay, so this is an example. So makikita natin dito, yung right side, 0.57 ang computation, while the left side is about 1.13. Okay? So if you get a 0.57, how do you interpret? So for the diagnosis, you interpret each leg separately. The normal ADI is about 1 to 1.4. Borderline is 0.9 to 1. And below that is abnormal ADI already or low. But you have another spectrum. Meron din tayong abnormal ADI if it is higher than 1.4. Okay? So you measure both legs. So again, showing to you the consensus statement or the algorithm. If the patient has possible PAD, you get the history and has the risk, okay, for PAD. If the patient has no risk, then you don't need to do an ABI. If the patient has a risk for PAD, example again, kung may hypertension, diabetes, smoker siya, then you do an ABI. And then after you compute, kung normal yan, you can also do an exercise ABI and then check if it is normal. If the ABI is abnormal or less than 0.9, then you diagnose the patient with PAD. Kung equivocal or 0.9 to less than 0.1, you may do an exercise ABI, and then if it is abnormal, you diagnose the patient with PAD. Okay? Again, kung non-comprehensible siya, you may do ito yung sobra sa 1.4, di ba? Then, what you can do is your TBI, yung toe index, toe brachial index. Okay? So, you compute it again. Kung less than 0.7, then you diagnose your patient with PAD. Okay? So, medyo technical po, but you can do this in your areas. This is another recommendation. So, almost similar naman sila. Okay, this is from the AHA or American Heart Association or the ACC guideline. Okay, so if it is abnormal, then you can diagnose your patients with PAD. Kung kailangan pa, you need to do more assessment. You can do the Duplex Ultrasound, the CTA, or MRA. Okay, so now let's proceed with the recommendation on PAD, on foot care. So later, kung may mga questions pa kayo, we will entertain them. So we know that most foot problems are preventable. So kailangan lang natin ma-identify early at ma-treat early by our skilled health professionals. So again, you perform annually yung foot evaluation, especially to identify the risk factors. And then at every visit, you examine your patients. These are the history that you should take note of. Okay, lalo na yung may mga current symptoms of neuropathy and vascular diseases. Also, examine for the skin, neurologic assessment, and vascular assessment, including the pulses. So what do you want to look for? Okay, so look for bruises or cuts or blisters. Okay, baka mahilig sila magsusuot ng mga masisikip na sapatos. Ito, crack heels, we usually see them among our farmers. Okay, dyan din sa mga ibang lugar, sa mga farm areas, mga farmers natin, lalo na kung may diabetes. Tapos yung mga may calcio. Yan. Check po natin yan. Hammer toes, kung mahilig sila magsuot ng mga masisikip na sapatos, kahit maganda pa siya tignan. Then, clawed toes, may mga bunion, especially yung mga elderly patients, may mga Charcot's arthropathy or flat-footed. Tignan din natin yan. They are at risk. Ngayon, ito hindi naman mahirap tignan kasi pupunta na sila talaga sa inyo, especially if they already have the foot infection. Okay, namamaga na yung toe kasi nabangga or meron silang mga infection like your tinea pedis. So again, palpate the pulses, okay, in the dorsalis pedis and the tibialis posterior. Check for coolness of the feet and toes. You may poor skin and nails or absence of hair in the feet. So to prevent this, 49 to 85% of amputations can be prevented basta makita natin agad. And education of people with diabetes and the health professionals. So, kaya lang minsan yung mga pasyente natin hindi na makapunta ngayon, di ba? Especially last year. Ayaw nilang pumunta kasi natatakot sila. Natatakot sila sa COVID. Pero yun pala, hindi pala yun ang dahilan. Okay? Natatakot sila, okay, hindi sila makalabas kasi hindi na sila magkasya. Now, let's proceed with this. Okay. Second picture. So, yung third picture, sigurado, kilala niyo siya. Right. Okay, so the word we are looking is diabetes. So, symptom ng diabetes yan, polydipsia, yung complications, it would involve the blood vessels. So, treatment for diabetes is your insulin. And Mike Enriquez is a type 2 diabetic patient. Now, let's take a look at the bad. Sino ba yung bad? So, baka yung bad yung diabetes. Okay? So, with diabetes, it increases the risk for PAD. So, looking at the prevalence of PAD, ikaw normal yung blood sugar mo, but you are already at risk as much as 12%. Kung ang pasyente natin merong IGT o impaired glucose tolerance, it increases to 20%. And if the patient is diabetic, almost 22% at risk. So diabetes is a prothrombotic state characterized by accelerated atherosclerosis and inflammation. So you can see the physiopathology of having diabetes. So pag sobrang taas ng sugar, kung marami kang free fatty acid, and if there is insulin resistance, this would promote oxidative stress, protein kinase activation, your uh, AGE activation, or your alpha-glycated uh, glycated activation, mga products. So this would lead to vasoconstriction, inflammation, and thrombosis, particularly hypercoagulation and platelet activation. So ganyan na nangyayari kapag may diabetes. So let's focus more on the thrombosis. So diabetes is a hypercoagulable state. Ibig sabihin, there is less of fibrinolysis with more of coagulation. So lagi natin sinasabi sa mga pasyenteng may diabetes, kahit wala silang sakit sa puso, pag may diabetes ka, lumalapot yung dugo. Now, with that, review natin tong clotting hemostasis. So, pag na-damage ang blood vessels, it will stimulate your clotting factors. And this would be stimulate also your prothrombin to be activated into thrombin. At yung thrombin naman will activate your fibrinogen para maging insoluble yung fibrin. Okay? Which is an insoluble product. Now, yung thrombin kailangan, o yung fibrinogen kailangan because of the formation of the platelet plug. At yung fibrin naman, these are strands para ma-develop yung clot para hindi siya matanggal. Okay? So, yan yung normal hemostasis. Now, how do we reduce the risk of thrombosis? So, if you want to interfere either with platelet adhesion or aggregation, you give an antiplatelet drug. If you want to inhibit the clotting mechanism, you give an anticoagulant. If you want to degrade yung fibrin, okay? So, or fibrinogen, you may give a fibrinolytic agent. Okay? So that, having said that, ito yung mga kailangan natin to reduce the risk of thrombosis. Kaya minsan, di ba, mapapansin nyo, bakit nag-MI pa rin? Naka-anticoagulant naman. Bakit nag-MI pa rin? Naka-antiplatelet naman. So, this is the classification of your antithrombotic drugs. So again, we have antiplatelet, anticoagulant, and fibrinolytic drugs. And these are the actions. So, hindi ko na kayo iisa-isahin dito sa action ng mga gamot natin. So, just to show you, you have different drugs that acts on the different pathways. Okay? So, ito yung mga bago. And then you have your aspirin and your clopidogrel. And you have your mga bago natin, mga low molecular weight heparin. So, looking at this class of drugs, so meron tayong mga antiplatelet, meron tayong mga anticoagulant. So, anong napansin natin? Wala tayong masyadong fibrinolytic agents. Okay? So, now let's go to the treatment. So, in treating your PAD, syempre, lagi naman, smoking cessation, healthy diet, and physical activity. And if you have PAD, it is recommended that all patients would receive statins. Okay? And then, ito yung recommended goal for patients with PAD to reduce the LDL cholesterol to 70 milligram per year. So, in patient blood sugar control, you may give antiplatelet therapy or like your aspirin. You should control the hypertension to a BP of less than 140/90. And you give an ACE or an ARB as first-line therapy. And this guidelines comes from the ESC guidelines. So, ano na ba yung good? Okay? So, nakita na natin yung bad, yung ugly, and this is the good. So, this is Disolf. Okay? This is DLBS 1033, which is a major breakthrough in improving blood circulation in diabetes. So, this is the lumbrokinase. So this comes from the earthworm. So we know that it has been traditional Asian medicine, And a Japanese researchers have purified and characterized a group of serine protease enzyme from the worm or the lumbricus, and then they called it collectively as lumbrokinase. And this has been studied thoroughly. So your lumbrokinase enzyme is a bioactive fraction. Okay? So dumaan na yan sa madaming stages or process to get a bioactive fraction. Tawag na nga nila dyan ay lumbrokinase. And this is produced in a GMP environment. And ang maganda dito, because of its unique characteristic, the molecular weight is less than 100 kilodalton. Ang tawag din sa kanya, lumbricus low molecular weight protein. Okay, di ba? Sounds familiar kasi ang ginagamit natin yung mga low molecular weight heparin. Now, this is the mechanism of action of your Disolf or your DLBS 1033. It has antithrombotic property, which is antiplatelet and fibrinogenolytic. It is also thrombolytic because of its thrombolytic and fibrinolytic properties. So, tignan natin. So, again, antiplatelet siya. Okay? So, it acts by inhibiting the phosphodiesterase 3. Okay? So, hindi ma-convert yung 5-AMP to cyclic AMP. Kaya maiwasan natin yung platelet aggregation. It has a fibrinogenolytic activity. So, as you can see, ito yung Disolf can decrease the blood viscosity level. So, hindi siya masyadong malapot. Okay? So, after giving your Disolf, na-degrade niya yung fibrinogen. Your Disolf also has fibrinolytic activity. Okay? So, it acts dito sa TPA. Okay? So, it increases your TPA para mas marami ang plasmin. Now, it also lyses the clot. Okay? So, yung fibrin natin, dami, mga strands na yan, tinutunaw niya yan. It penetrates into the blood clot, cut the fibrin, and dissolve the clot. So, having said that, ito yung, again, yung mga drugs natin, di ba? And their mechanism or yung sites of action. So, saan ngayon natin ipoposition yung Disolf? So, we can place your Disolf here. Dito, it acts on the fibrin and fibrinogen. And it acts also on the platelet aggregation. Okay? So, fibrinolytic and fibrinogenolytic agent siya. Now, just to show you some studies on the use of Disolf. So, ito yung mga studies in Indonesia. Okay, so you have a 47-years-old female diagnosed with deep vein thrombosis. So, the patient has total thrombus occlusion in the femoral vein of the right. Okay, so binigyan siya ng Disolf for 2 weeks, 1 capsule 3 times a day, aside from the other drug. Then after 2 weeks of treatment, there is recannulation of the vena femoralis. Another patient has acute limb ischemia. So this is a diabetic patient, 60 years old, nagkaroon siya ng acute limb ischemia. At meron pa siyang atrial fibrillation, okay, and stage 1 hypertension. So, dapat dito, surgical na, okay, surgical thrombectomy, but the patient refused. So, what the doctors did is to give him Disolf, 3 tablets, 3 times a day, okay, aside from his other drugs. So, ito yung itsura ng CT angiogram ng patient. So, initially, okay, up to day 4, makikita natin walang flow ng blood, okay, dito sa, especially this right lower extremity, okay. After mabigyan siya ng Disolf, there is better contrast flow on both legs, okay. And after 2 weeks of treatment, ito na, maganda na, the patient was discharged with good condition. And after day 50, okay, halos normal na yung contrast flow on both legs. Okay? Sa atin, hindi natin masyado magawa to kasi because of, siguro medyo mahal siya. Mahal sigurado itong test na to. And minsan, we go clinical. So, another study, this is the Disolf PAD case study, looking at small number of patients, they were given Disolf. So they included patients with PAD with intermittent claudication and an ADI of less than 0.9. Okay? So yan ang mga characteristic ng patient. So the result shows that your Disolf improves the ADI in patients with intermittent claudications. So before treatment, yung orange at yung red is your post-treatment as compared to your placebo. So very significant ang improvement ng ADI. Also, comparing control and Disolf, so there is improvement of the ADI from the baseline among patients given your Disolf. Nag-improve yung kanilang intermittent claudications. So, in conclusion, PAD treatments are available to protect the patients with PAD from future MI or stroke. And your Disolf or your DLBS 1033 is a natural and patented fractionation process, natural enzyme, okay, extracted from a Lumbricus probellus in a GMP environment. And it is a potent thrombolytic effect which dissolves your fibrin clots. So it improves your ADI in patients with PAD. So safe ba siya? So meron na rin sila mga study. There is no significant change in the safety parameters of your Disolf. So it is safe and well tolerated. Tingnan natin yung ALT, yung kidneys, and yung mga clotting parameters. So Disolf is indicated to improve your blood circulation. So pwede siya as secondary prevention for patients with ischemic stroke. Meron silang study on that. For patients with MI, with CAD, or with PAD. And you can also use it as a primary prevention for high-risk patients. Lalo na may mga diabetes mellitus, may mga CKD also, we can use it, itong Disolf. So how do you give it as a therapy? Kung may acute limb ischemia or merong PAD, you can give it 1 tablet 3 times a day. Now, for prevention, you can give it 1 tablet once a day. Ang contraindications lang, syempre, those who have blood coagulation abnormality or those who have a known allergy to one of its components. And with that, we have discussed, okay, peripheral artery disease, okay, including the treatment using Disolf. At ito lang po, lastly, yung mga key points in peripheral vascular disease. So blood flow is restricted to the tissue because of spasm or narrowing of the blood vessels. And this disease more often affects the blood vessels in the leg. Okay, take note also that the most common symptom is pain. And again, sometimes walang complaint. Okay, the pain which becomes worse at the circulation are more limited. And we need to restore the blood flow and prevent disease progression as our goal of treatment. So this is your Disolf. It's a natural and potent oral thrombolytic agent. So thank you very much for your attention. And I'll give the screen back to our beautiful Ate George. Thank you.
Thank you very much, Dr. Danny, for that very extensive, very detailed discussion of the role of Disolf in the management of peripheral arterial disease. Okay, may I remind everyone to type in your questions and verifications in the Q&A box. And as you were giving the lecture, we are able to gather some questions and verifications regarding your talk. And congratulations, Dr. Danny, for a very informative lecture. I learned so much, and I think everybody will agree with me that they learned from your discussion as well. Okay. If a patient is already on aspirin or clopidogrel, can we combine it with Disolf, or there is increase in incidence of bleeding if we do this combination?
As far as in my practice, yung mga patients na nakikita ko, I usually combine them with only one. So ang combination natin, 2 drugs lang. Okay, so it's either aspirin plus Disolf or clopidogrel plus Disolf. Okay, so yun ang recommendation din nila is to combine it with another drug, pero hanggang 2 lang. But in some patients, minsan 3, naka-triple antiplatelet sila. Kaya lang, because of the action nga, kasi we are using it as a fibrinolytic agent. So you can combine it with that antiplatelet. So it's either aspirin or clopidogrel. So ganun yung
What about
ginagawa ko.
yes.
Yes.
So what about Dr. Danny for patients who are already on blood thinning agents? So you have mentioned the warfarin or patients on other blood thinning agents as Pradaxa.
Yeah.
Can we combine it with that?
Wala pa akong experience with other anticoagulants like warfarin or Pradaxa, but sa mga studies nila, wala din masyado. But I think there are indications kung bakit magbibigay ka lang ng warfarin or magbibigay ka ng ibang gamot Pradaxa. But in general kasi, more on peripheral arterial disease, yung nagagamitan ko nitong Disolf. But I also use it. May mga patient ako na may mga CKD, na bibigyan ko din sila in combination with other drugs o kaya as monotherapy lang din, as prevention kasi high risk sila. But in combination sa mga other blood thinners, wala pa akong masyadong experience. Sa mga Tulodexide, na i-combine ko din siya o kaya sa Silostazol, nako-combine ko din.
Yeah. Okay. So, is there any study comparing Disolf with other antiplatelet medication?
Meron silang ginawa. If I'm right, if I remember it right, Sir John, yung sa mga patients na merong infarct, cerebrovascular disease. Tama ba, Sir John? Yun yung ginamit nila na tama? Hindi ka namin marinig. So I think that's one study na ginawa comparing aspirin and clopidogrel. And then may measure sila about sa mga stroke patients kasi ito eh. So ang nakita nila parang much better yung outcome sa mga pasyenteng nakadisolve than aspirin or clopidogrel. So, yun nakita nila sa study.
Okay. So, most of the patients we encounter in practice are particularly among diabetic patients have concomitant diabetic foot. And most of these patients will require surgery. If these patients are already on Disolf, how long prior to surgery should we discontinue using Disolf? Or we can just continue with the Disolf even
similar with other anticoagulants or antithrombotic therapy, you have to discontinue it mga 5 to 7 days bago mag-surgery.
Yeah.
So, okay. And then after that, balik na lang natin para prevention, para yung kabila naman hindi rin masira.
Okay. So, for our patients who would require prophylaxis already with diagnosed PAD but still manageable, how long should we recommend these patients to take Disolf? For how long?
Yung mga high-risk patients natin, ang ginagawa ko, simula nung na-encounter ko tong medicine and I've already started them on this. Hanggang ngayon, naka-maintain sila eh. Hindi ko pa rin sinatanggal. So, especially lalo na yung mga nagkaroon na, yung nagkasugat na, nagka-post ulcer. So, maintain. Tuloy-tuloy lang din siya. Kahit once a day siya.
Yeah. Okay. So, another question is, since our patients are mostly high-risk patients with a lot of comorbidities and are taking several classes of of different
Oh, yes.
medications, not just for diabetes, for the heart, for hypertension, etc. Is there any known drug interaction with this medicine?
Based on their studies, wala silang masyadong nakitang interactions with other drugs. So it's very safe, even if the patient is taking multiple drugs. So safe naman po siya.
Okay, we have one question from an anonymous attendee. Is Disolf recommended to any categories of ALI?
ALI, acute limb ischemia siguro yun.
Yeah, probably.
Yung siguro you will encounter this sa mga different lectures, yung Asia Pacific Consensus. Sa mga recommendation or sa mga guidelines, wala pa po siya sa mga guidelines kahit sa ibang international guidelines. Wala po sa recommendation. But if you're talking about it, the drug mechanistically, so makikita natin pwede siyang gamitin. Kaya nilagay ko yung position niya kasi yung mga drugs natin na na-mention, aspirin, clopidogrel, sulfoxaflor, makita natin nandun na talaga kasi they have been there and there are very large trials na. Pero dito sa Disolf kasi wala pa din masyadong large trials, but if you're going to look at how they describe the mechanism of action, makita natin may gamit siya. Although, yung nga sabi po wala pa po to sa guideline. But kung ako personally, ang tatanungin din, I will use it in patients with acute limb ischemia.
Thank you. And I'd like to thank Dr. Marita Palyarca for her question on for how long shall we give Disolf. That has already been answered. And can you discuss to us possible contraindications with Disolf, Dr. Danny?
As what in the lecture, yung mga mayroong allergies sa components of the drug at saka yung may mga bleeding talaga na sakit sila. So baka lalong mag-aggravate yung bleeding. So yun lang naman yung dalawang contraindications.
Oh, yeah. Okay. So we still have, I think, the last two questions from Dr. Marlon Manicad. He says, it's a very interesting lecture of Disolf. And may I ask, what is the maximum dosage of Disolf and what component of Disolf are we going to remember to avoid allergy?
The maximum, yung sa isang study nila, they gave 3 tablets 3 times a day. So that's already 9. So ang recommended kasi nila 1 tablet 3 times a day lang. So I think it is safe to use kung yun yung nakita din nila. And then yung component ng Disolf, I'm not sure kung anong meron pa ibang laman, but usually it's the drug. Tapos syempre kung nandun sa kung paano ginawa yung drug. I don't know kung paano ko sasagutin to, kung anong laman niya. So anyway, so hindi ko alam kung paano kung
the low molecular weight lumbrokinase.
Siguro may allergy ka sa bulate. Hindi ka just joking.
And the corollary to that is, if there is an acute allergy or side effect to Disolf, how are we going to reverse it? Did you encounter something like this?
Wala pa So I've been using it more than 2 years na kasi, pero wala pa naman akong nakita na nagka-allergy because of using the drug. Siguro kung magkaroon naman siya ng allergic reaction, then yung ating conventional na ginagawa pag nagagamot ng allergy.
Yeah, and you made a very nice presentation about the limb ischemia. that was able on the patient who refused surgery and was able to be documented in CT angio. That was parang
ganda, no?
yeah, that is very nice and very convincing. So I think our speaker have practically answered all the queries regarding his lecture. And I know that you will all agree with me that what we have learned tonight contributed much to our knowledge on how we can efficiently manage our patients with peripheral arterial disease in our at-risk patients, particularly those with diabetes. So from the strong data that was presented by Dr. Danilo Baldemore, as well as the long duration of clinical experience. So again, in behalf of Glorious DEXA Mandaya, I would like to again thank our very eloquent speaker, Dr. Danilo Baldemore, for sharing his valuable expertise. So this is Dr. Jocelyn Muli Marcos. I'm called Ate Georgie, your moderator. Good night, everybody. Thanks for your attendance and for listening.
Thank you.
Thank you, Danny. That was a nice presentation and a very interactive discussion. Salamat po.
Thank you po. Ay, ang dami nating audience.
Yeah, it reached up to 84.
O baka may nagtanong siguro kung magkano, ha?
Wala. Naku, wala nagtanong. Sorry, nakalimutan ko. I should have asked that one.
Andito pa naman si Sir John. Baka gusto mo sagutin.
John, how much?
Para idea
still, pahabol question, how much is at Disolf? Sir John, pahabol question, how much is Disolf? Muted. You are muted, John.
Okay, Doctora. Yes. You hear me? Okay. Doctora, mercury price, Disolf is 44 pesos per tablet.
Or if there is senior citizen?
Yes, Doctora. Senior citizen can be availed by the patient.
How much na? So less than 20, parang 30 plus. Okay. So that's a good, so for prophylaxis, you spend like that. Okay. Thank you very much.
Thank you.
Yes.
Thank you, Jeff. Dito pala si Jeff. Si Eric pala nandito rin.
Yeah. Thank you sa friends ko from Mindoro, Dr. Birong, Dr. Ingrid. Thank you.
Kita mo na, ang bata mo daw ngayon.
I have one from my friend. Ang gorgeous mo ngayon, mama.
Diba? Hindi naman lang ngayon, lagi.
Real hair.
Papang headband yun. Nag-headband, mas bata pa.
Nice presentation and nice. Ang daming umattend, ah. Ang daming attend.
Relative ko ba sa'yo? Geraldine Marcos? Good night.
Good night.